Okay, so good evening, everybody. I hope my screen is visible.
Yeah, it's visible.
Yeah. So I'll be presenting a case, and just for the discussion's sake, how IVUS helped me in each and every step. This is a case of left main angioplasty. So this was a 53-year-old gentleman who presented with angina, unstable angina. His ejection fraction was normal, the right circulation was normal, and the left showed a tight ostial LMCA stenosis extending up to the whole body of LMCA. So now, what were the options I have? Should I offer him a PCI? If PCI, what should be my approach? Whether it should be a provisional stent strategy, or right from the word go, I should plan elective double stent strategy, or should I offer a CABG? Now, since the patient was not willing for CABG, a PCI was offered, and plan was to go ahead with a provisional stenting strategy, and let's see how he behaves. And at any point, I was willing to convert it into a double stent strategy. And I intended to use IVUS at each and every step. And let's see how IVUS helped me in each and every step. So I went ahead with angioplasty. A 7 French JL guide was taken. The lesion was crossed. And then this was the IVUS done. Sorry. Now this I am entered through both the circumflex as well as the LAD. I wired both the vessels, and this was the IVUS for to the circumflex. Now this IVUS helped me in identifying that this circumflex ostia is free of disease. If you see this IVUS closely, if you measure the MLA at the circumflex ostia, if you see this is the circumflex ostia, this is the LAD we are seeing. This is exactly at the ostia. MLA was around 9 millimeters square. So clearly we have a very good MLA. Circumflex ostia is free of disease. So my strategy of provisional stent strategy was very good in this, and then IVUS confirmed it that I can go straight away from LMCA to LAD. As circumflex is not disease. If it's something circumflex gets pinched, then I can take care later on. Now this was a LAD pullback. Now you can see. Now LAD pullback also gave variable and very valuable information to me. It gave me what the stent size should I use, what is the distal reference diameter, what is the LMCA diameter, what is the length of LMCA, what should the length of the stent should I take, and I'll describe each and every step step by step. This is just a run. Watch it closely. This is a pullback from the LAD into the LMCA. Now, information what I gathered from this. First of all, morphology of plaque. I was very sure that this is we are dealing with a fibrofatty plaque. There's hardly any calcium visible. So the plaque modifying strategy can be simple. I don't need to use a debulking strategy or rota or anything like that. I'm dealing with a very soft fatty plaque. This is the morphology which the IVUS told me. Is my voice echoing or what?
There is some echo, Pankaj, but
from my end, is it better now?
Yeah, this is better.
Yeah, it's better.
Okay. So the first thing which I gathered from this, we are dealing with a soft fibrofatty plaque. There's no significant calcium in the.
He has frozen.
It was around 3.5 to 3.6. So a 3.5 millimeter stent should be taken here. The third information which I gathered from the pullback from the LAD, we can see the circumflex ostia. Though I've seen circumflex ostia directly from the circumflex also, but here also you can see from the LAD, the circumflex ostia is again free of disease. So I'm audible?
Intermittently, Pankaj. It's getting broken in the.
I don't understand. What I'll do, I'll just put my video off. It will increase the.
Yeah, that's better. That's okay.
We can increase it now. Now this is the pullback from the LAD again. Again, re-emphasizing the fact that circumflex ostia is clear of disease. You can see this is circumflex ostia originating. This is the LAD. Now, the fourth information which I gathered from the LED pullbackers, the diameter of LMCA is 4.5. So I need to take at least 4.5 millimeter diameter balloon for pot after putting a stent. So this is the diameter of the LMCA, is around 4.5. Sixth information which I gathered from LED pullback is that the whole of the LMCA is disease and the length of LMCA is 6 millimeter. This you can see here, LMCA starting, here is the aortic ostium. In between is the length of LMCA. So I am dealing with the LMCA of 6 millimeter length. Again, this is very important because of the pot balloon, which I am supposed to take, should be not more than 6 millimeter or not more than 8 millimeter at least, because the diameter of LMCA is only 6 to 8. Though in this case, it may not be very relevant because I have to stand right from the ostia. So I can pull this balloon into the ostia also. But in other case, it is very important to know exactly what is the length of the LMCA so that the length of the pot balloon which should be taken can be chosen wisely. So LMCA was around 6 millimeter and whole of the LMCA was disease. Seventh, again, a very important information which I gathered from this, to see the carina. Now this carina information is very useful, which we gathered from the IVUS, is that because if it is not a favorable carina, then we know that this favorable is carina. Just look at the second slide. This is what the eyebrow sign is. This hairy looking circumflex carina. You can see this pointing carina. This we call as eyebrow sign. Suppose I put a stent from LMCA to LD. This is not for my case. Suppose I put a stent from LMCA to LD. This carina will shift. You can see this pointing. This will shift down and it can close the circumflex. On the contrary, look at this carina. If I put a stent from LMCA to LD, this is a downward pointing carina and this is favorable carina. If you go back to our case, again, it's a downward pointing. It's not upward pointing. It's not hairy, spiky carina. So I am dealing with a favorable carina. So IVUS again gave me this very important information that I know that my circumflex is not going to close after putting LMC to LD because of the favorable anatomy of the carina. Again, a very important information which I gathered from IVUS. So again, the last information, what's the stent size? Right from I have to start from the ostia. This was my distal landing zone. If you measure from the proximal landing zone to distal landing zone, it comes to around 12.5. So I choose a stent of 3.5 into 13. Accurate stent choosing can be chosen by this IVUS. So all this 7 to 8 information, very important information I gathered from IVUS. So based on this, I put a 3.5 into 13 millimeter stent. This is how I choose the length of stent. This is the distal landing zone. This is the proximal landing zone, and in between should be the length of the stent. This is how we choose the length depending upon the IVUS findings. So provisional approach was applied. This is a 3.5 into 12 millimeter disc was deployed from the LMCA ostia into the LED, and this a 4.5 millimeter balloon was used to further optimize the result. Now, how does IVUS help me in post-plasty? This was pre-plasty. Now I have done my angioplasty, I did a pot. Now I need to confirm with the IVUS. I need the help of IVUS to see, first of all, whether my stents are opposed, whether my aortic ostium, left LMC ostia is covered or not, whether there's some distal dissection or not, and what is happening to the circumflex. All this I can see very beautifully with the IVUS. Now this is the post-implant, post-stentic IVUS. This is the LED pullback. Now you can see a very well expanded stent. LMCA ostia is well covered. I'll discuss each and every. There's no edge dissection. Again, you can see this is the pullback. All the three information I'll discuss separately. But you can see very well expanded stent. Now you start seeing the aortic ostia. So this is. Here comes the aortic. You can see the stent is completely covering the LMC ostia. Now you see the very well expanded stent. A very good MLA was achieved, almost around 12 millimeter in the LMCA, which is acceptable. Secondly, the aortic ostia is very well covered. You can see here. You can see this is the aortic ostia, and my stent is behind the ostia. So clearly, IVUS is confirming the fact that ostia is well covered. This was the final pick. You can see angiographically also it looks reasonable, very well, satisfactory result. This is the caudal view again showing a good result. The circumflex was flowing. Patient was having no angina. Now the next question which comes to my mind is, should I do a final kissing balloon inflation? Because there was no, as such, no clinically there was no pain or ECG changes. Hemodynamically, patient was stable. Angiographically, there was no significant plug and with a TME3 flow. Why? Whether I should go ahead and do a final kissing or not. Now again, IVUS helped me in deciding this fact. What I did was, again, I crossed with again recross the struts through the LMCA ostium and LLD stand, and this is the pullback, which this is the LCX pullback after recrossing. Now you can see this is a recrossing.
Last 1 minute.
Yeah, should I stop, sir?
No, last 1 minute.
Yeah, yes, I'm just closing off. This is the LCX pullback after recrossing. Again, you can see the pullback from the LCX clearly suggests that again the ostia is not very much pinched. MLA is still around 9 millimeter. So again, a very good information which I gathered by recrossing the circumflex struts and doing the IVUS again. Again, you can see the pre-stand or post-stand. There's no crinal shift, as you can see. This is the pre-stand, this is the LAD in circumflex. Again, this is the LAD stand and this circumflex. Again, you can see the carinal, there's no carinal shift, beautifully seen with the IVUS. So there's no need of any final kissing in balloon inflation because the MLAs are good, was good for the circumflex. There's no carinal shift. So I didn't do any final kissing in this case because IVUS didn't suggest me to do so. So again, the data also, I will not go into the detail whether to do final kissing or not. There's no final word to this this question, whether to do a final kissing in a LMC ostia or not, in an LMC to LAD stand or not, is still a debatable issue. The point of interest in presenting my case is IVUS is like a third eye of intervention cardiologist. IVUS can help you in each and every step of LMCA plasty, and the precision angioplasty with IVUS can take away the mystery of LMCA angioplasty. So, just ladies and gentlemen, IVUS or intracoronary imaging are the glasses of modern day intervention cardiologists who do not like blind decisions. So thank you everybody for the patient listening.
Thank you, Pankaj. It was a wonderful showing that how imaging can make the outcomes best. Let's have some discussion. I think Dr. Gautam has been assigned as a discussant on this. Dr. Gautam, over to you. You want to say something or ask?
So we all know that the IVUS is a class 1 indication in the LMCA angioplasty, and what Dr. Pankaj Manoria did in a bookish manner, and he explained each and everything regarding the pre-procedural planning, during procedure, and after procedure assessment of this imaging. And definitely we all know that these all kind of tools make our procedure more in a long-term fashion durable, and the data also suggests that. So my my additional point in his case that one should always plan for the in such kind of the angiographical picture, one should always, if IVUS is not available, one should always plan a provisional stenting. Then after provisional stenting, and always try to do what your eye sees, always post dilate 1 point higher to the non-compliant balloon. If your gut feeling is saying that this artery is looking like 4, go to the 4.5, at least 4.5 most of the time. Sometime I might post dilate 5 millimeter non-compliant balloon in these kind of the LMCA lesions. And after that, the main role of the IVUS is after that the assessment of the LCX pinching. If you find that the LCX is the major branch and it is pinched with provisional stenting, then IVUS help in this kind of scenario. And again, doing ballooning or not ballooning is always a debatable topic. In most of the forum, we always discuss that the port, side port, or only port. What should be the proper strategy? Some doctors advocate that the open the stud for the LCX for the future revascularization. Some says that the
I think that Pankaj also covered that it's a debate.
Yes, yes.
But yes,
so overall, it is a
I
good
agree
case,
with
and it
all
is
the
a great
comments.
learning case.
Even Gautam has covered. So IVUS makes us a lot wiser in planning our intervention. There is no doubt about it. And especially if we are planning a bifurcation, or especially if it's a left main bifurcation, IVUS gives us lot of clarity ideas about how to size a stent. Like Pankaj has very beautifully given the overview, like which balloon for the pot to be used, how much is the left main length. So he has actually covered all intricacies of all the points which IVUS gives a detailed information to us while planning a case. And this is the best possible manner we can uh, give the best outcomes to a patient. So if we can use imaging, nothing like it, nothing like it. Now, always a debate whether OCT or IVUS, both are good, I feel, except for barring a certain situation where OCT, like in osteal things, OCT misses out the ostium. IVUS, OCT misses out the ostium, so IVUS is better. But uh, resolution wise, OCT is better. But IVUS also gives us lots of information. So I think this is a beautiful message.
One small comment I would like to add, that if you want to do the proper justice of this IVUS imaging, try to evolve the minimum contrast way of doing this thing. Make the wire looping into the aorta, and make the positioning with the Sajo technique, and try to evolve the technique if you want to truly justify the IVUS imaging with the in this kind of procedure. It will again emerging technique. And number two, that the Medtronics is having a telescope kind of micro catheter. If you want to use OCT, if your lab is having OCT, then with the telescope you can use OCT with the left main intervention as well.
Yes, actually, I was going to say that. So there was a time when we were doing a left main case and we had only OCT on the block and we were doing a live case. So what we did is we took the telescope. The proximal 2 millimeter tip of the telescope is actually infrared compatible. So you can use that to see the left main ostia. And that's how you can use OCT in the absence of IVUS for ostial left main also. So that's one of the ways. And I think the question which always comes, Dr. Pankaj, very nice case and very nicely done, and excellent demonstration of how IVUS really helps us in such cases. But I think the question about, whether to finally dilate the circumflex ostium or not always arises when you don't have imaging and you can't demonstrate that, there are no struts across the circumflex ostium. So that's when, when you don't have imaging and you don't know if you've got any struts across the circumflex ostium, and the future of a fenestrated restenosis, which we always talk about for a future operator, that's when most operators like to just take in a balloon and do a low pressure dilatation to remove the struts.
I think that's
the left main angle,
I
assessment,
totally agree.
the left main angle is very important. In your case, the angle is actually an acute angle. It is like a 45 to 70 degree angle of the left main to the LD and the LCX. If you find that the angle is around 90 degree, that you are pretty sure that you are not going to pinch the LCX ostia. But in the condition like your case, if the angle is narrow and acute angle is there, the role of IVUS is very important.
I think point well taken. Point well taken. For the sake of time, let's move ahead. But it's a beautiful case,
Yes.
Pankaj. All compliments to you.
Thank
And
you.
keep sending us your further
Thank you,
videos also. Okay. So
Thank you.
let's move on to the next case. But Dr. Tejveer.